So, good afternoon, everybody. Thanks for joining today for the sixth chapter of the NABH entry-level education webinar series. Today, we have a very eminent speaker, Dr. Nirmal Fredrick. He is the MD of Nirmal Eye Hospital, Chennai. He has played several roles, not just being an ophthalmologist, but he has been actively involved in quality initiatives in his hospital and outside the hospital as well. He is also the chairman of the academic committee of the Tamil Nadu State Board and also the vice president of the Tamil Nadu Ophthalmology Association. He has received, he's been recognized by several institutions and organizations across for both his surgical skills and otherwise. He is also the author of the NABH ICAS standards and AAO's book on accreditation of eye centers. So welcome, Dr. Nirmal Fredrick. Thank you for joining us, sir, today.
Thank you.
Dr. Nirmal Fredrick, sir, he will be talking about CQI. And over to you, sir, please.
Thank you, Adel, and thank you, CAHO leadership, and the South Zone Chairperson, Mrs. Rama Rajshekharan, and Mr. Adel for this opportunity. Let me share my screen. So I welcome all the participants for this NABH education series organized by CAHO South Zone. So I need thankful to the leadership for selecting me for this particular topic. I'm sure you've gone ahead with the patient-centered standards the last 5 weeks. 5 chapters you've already covered, and that makes the job quite easier. And now we move on to the organization-centered standards, that is called continuous quality improvement. So this chapter basically introduces you to the subject of continuous quality improvement and patient safety. And now in the 5th edition, this is known as patient safety and quality, PSQ standard. So let's move on. What is in store? So continuous quality, what exactly is this? So basically this chapter attempts to answer few questions that we come across during the quality journey. So how are we doing? How can we do it better? Can we do it better? And more specifically, can we do it more efficiently? Can we be more effective? Can we do this a bit faster? And can we do it in a more timely way? So if we can answer these questions, so we have understood continuous quality improvement. So basically from a current state to future state, we go through a process. People are involved in this process, and we adapt certain technology and tools to see how we are going through this process. So we have a lot of learning during this process, and that learning leads to continuous quality improvement. So it also helps to improve patient care, improve the health of our population, and reduce the cost of operations as well as the cost of care delivery to our patients. So basically, continuous improvements begin with the culture of improvement for the patient, the practice, and all the stakeholders. As you are aware of that, any chapter of NABH, all the 10 chapters has its own intent. So the intent of this particular chapter aims at encouraging an environment of continuous quality improvement, and of course should involve all areas of the organization, right from the basement to the rooftop, from the gate to the backyard, and all areas of the organization, and all staff members from doorman to chairman. And the improvement should be sustained. So this is more important because many organizations, when they go through this accreditation process, they achieve the certification or the accreditation, and after that they get slacked. So the improvement what they achieve during this accreditation process should be sustained and should be able to move forward. So this particular chapter, as far as the entry level is concerned, there are 2 standards, CQI 1 and CQI 2. the first standard focus on quality and safety programs for the organization. And the second standard focus on the key performance indicators. So for entry level, it's much easier because only 2 standards, unlike the 5th edition, which has 7 standards for the larger hospitals. So let's go one by one through the standards and the objective elements. So this particular standard says there is a structured quality improvement, patient safety, and continuous monitoring program in the organizations. So the objective elements are, there has to be a designated individual for coordinating and implementing the quality improvement and patient safety. So this is important. So for any organization to implement a quality improvement program, you need an individual who can coordinate, who can train the people, who can bring the team together and start implementing the new standards. And the second objective element is quality improvement and patient safety is a continuous process. So any program, structured program, has to be continuous and it has to be updated. NABH mandates that it is updated at least once in a year. And the third objective element, of course, nothing happens without adequate resources. So resources, not only the fund allotment, but also the various resources, human resources, and the other technical resources that is involved for implementation of this program. So let's see how we can implement this CQI 1. So whenever you want to appoint a quality or safety manager, so he needs to have certain one job description as well as certain knowledge and functioning about the hospital. So NABH, as you all know, involves a lot of statutory requirements as well. So the quality manager or the quality in charge person has to implement these standards along with his current responsibility. He may be a doctor, he may be a non-medical person, he may be in the operations department. So once you ensure that he is appointed as the quality manager, he has to implement and improve the quality standard along with his current responsibilities. And obviously, you should know about the hospital, the various functioning, as well as the statutory requirement for that particular size of the hospital in that state. As health is a state subject in India, you should be knowledgeable about the state statutory requirements. And he has to have good communication, PR, and soft skills. This is important because the accreditation process involves a lot of working with the senior leadership, the doctors, the clinical people, nursing people, the administration people, and of course the last level people also. So this particular person has to have good communication skills, good public relations skills, and soft skills to manage such a large team. And he has to be familiar with NABH standards. One way of getting familiar with NABH standard is to go through the POI program of implementation, or the programs organized by CAHO at the basic level as well as advanced programs, and should be knowledgeable in implementing the improvement model. And he or she should be able to prepare training modules, analyze the training gaps for the staff, and put up a training calendar, have some checklists so that we don't miss anything, and also audit the various happenings and gap. You should be able to do a gap analysis and report to the top management as well as to the various committees. And you should also ensure periodic meetings, maintain the minutes of the meetings. So as you all know, there are a lot of committees that will get involved, like HIC committee or the CQI committee or the Code Blue committee. So it depends on the size and size of the organization, and you should be able to follow it up. So how to implement, apart from having a good quality or safety manager in roll call and orienting him to the requirements, the committee for overseeing this quality and safety committee should oversee both the quality and safety program. This committee should be able to monitor the key performance indicators and look at the incident reporting aspect and review the various incidents reported, And also take serious note about the patient complaints and feedback. There's a lot of learning that can happen with reference to feedback from the patients and the attenders. And the complaints have to be taken seriously because that will impact the patient satisfaction on the healthcare services. And they should also be able to monitor the facility rounds and the safety requirements and monitor the sentinel and other events. It's important as we progress, the organization does the incident reports properly and sentinel events are recorded and proper action is taken on that. And CPR and safety monitoring also one aspect. So certain points to remember during the implementation. One is the organization should have a proper quality and safety budget. This is very important because any new quality improvement program needs a lot of budgeting, certain resources, material resources like computers, printers, and apps or softwares. And PPE should be available for the housekeeping as well as for the clinical staff. And patient safety devices may be needed in the appropriate care areas. And the second important aspect is training of the staff. So most of the staff would not be oriented to NABH requirements or the NABH standards. They should be oriented on the NABH standards, the quality improvement journey, as well as patient safety requirement. And availability of adequate security personnel is also important for proper protection of the staff as well as the premises. And the quality manager, either it's a doctor, nurse, or administrator, as we already know about his responsibilities and qualifications. So he should be, his salary and requirement also should be budgeted in the quality budget. And the hospital organization needs to determine the need for full-time quality or safety manager. Smaller organization can have a part-time or a clinician who can look after this quality also. Again, this should be left to the management and the organization to decide. And give protected time to manage quality and safety programs. So this is important because quality and safety program needs a lot of time and other resources. So the in-charge person, the quality manager, should be able to allot time to the implementation and the follow-up of this quality parameters. So this number of quality managers or quality personnel is decided based on the composition of quality and safety team and also the size and complexity of the hospital. One frequent question we come across during assessment is what should be documented in the Apex manual. Since this is an entry level and introduction to the standards, so these are the aspects that should be documented in the Apex manual. A brief history of the hospital, the ownership details, whether it's a private limited proprietorship or a public limited company or an NGO run hospital. And the hospital should have its mission, vision, and quality policy. So this should be ideally written by the top management with the help of the team. And this should also cover the relevant aspect of quality and safety program. And what are the protocols that has been revised for the implementation of NABH program. And this updated Apex manual should be circulated to stakeholders. So during assessment, we see many hospitals will have a good manual, well printed and colored manual, but this will not be circulated to the stakeholders. What you would have seen is only a e-copy or few pages of the Apex manual. So ensure that the Apex manual is circulated to all the stakeholders. They understand the content of the Apex manual. And revisions and updations are part of manual updation, and this should be continuously done. And the revision should focus on annual plan on quality improvement and safety, the audit schedule, the plan for internal audits, and key performance indicators with the formula. Based on the size of the organization, the hospital might be having many key KPIs, and it's important that the hospital finalize the KPIs based on its requirements as well as the NABH standard which it is going to implement, and the formula is finalized by the quality team. The method of data collection, person who will be responsible for the data collection and analysis and who will be presenting it to the committee. All these things has to be decided by the quality manager and the committee. And the scope of various committees. You have to list out the committees that are going to work on this quality improvement program, and who will be leading the committees, and what is the scope of the committees have to be decided, and a training calendar has to be discussed, and what is the type of training going to give, who are all going to get involved in the training, who are the key resource personnel, and what would be the intent of the training program, and how to collect the feedback, how the feedback and continuous mechanism are there in the training calendar should also be decided by the quality manager and the quality team. So this is about the first standard. So the first standard basically deals with appointing a quality manager and involving various peoples in the committee and giving a budget for the various resources that is required for quality implementation. So the second standard deals with the CQI 2, identifies key indicators to monitor the structure, process, and outcome, which are used as tools for continual improvement. So this is important from the organization point of view, because the organization, once the team is in place, the team will identify appropriate key performance indicators in both clinical and managerial areas, and these indicators have to be monitored. So this is the second standard of CQI. So what is measuring? So before going how we are going to implement this particular standard, you have to know why measuring is important. As you all know, you can't manage what you can't measure. So once you measure, that has to be communicated, and target have to be fixed based on the measurement, and the various data metrics have to be given to the policy or decision makers. It will also help in self-evaluation. So these are the reasons why you need KPI for any organization, whether you are going to implement NABH quality standards or any other improvement measures or another improvement program. So you need KPI to monitor the company's health, to monitor the progress, to analyze the trend, to make adjustment and see whether the organization is staying on track, and to solve problems or tackle opportunities during the learning process. So it's important you collect data, as we say, in God we trust, and all others must bring data. So key performance indicators basically are certain numbers. It's most critical for the current and future success of the organization. The measurement is important because that can show trend, which can help us in understanding where we are staying now and where we are going to go further. And this can also help in comparing the results against standard. So basically, KPI is a type of performance measurement that helps you to understand how your organization is performing. So what to measure? This is the key question that many of the entry-level people ask. So it is a model that provides framework for evaluating the quality of healthcare. We have a Donabedian triad. The triad is nothing but most of you are familiar with. So according to this model, the quality of healthcare can be measured using three categories: the structure, the environment in which the care happens. So that is basically the infrastructure. The process, how the care is delivered, and third, if the structure and process are good, the outcome also will be good. So the impact on patients and the populations. So we'll go through this, since this is important, we'll go through this one by one. The structure is nothing but the platform and people. So what are the resources required? Platform is the infrastructure of the hospital. So right from the entry to the rooftop to the surrounding areas and the support areas. And people are the resources required to implement quality standards. So the number of staff and skill mix is very important. So you need to have a good human resource planning. We want to focus on implementation. And the organizational arrangement. So it's not only people, the people need certain equipment and tool to work. So the place for working, the gadgets needed for all this quality work, and also certain tools like apps and software, EMR, all these things are necessary. So it's not only the technological involvement, even the stationary items needed for quality improvement has to be budgeted out. And then the physical space required. So a lot of space arrangement would be needed for implementing quality. So that also has to be taken care of. And so that is the structure required for quality improvement. The second aspect is process, the way things are done, the action and decision taken by practitioners together with the users. There are various processes that happens in the hospital, the communication, the assessment process. The assessment may be for emergency patients, for outpatients or inpatients. The education, not only for the patients, but also for the staff who are going to provide the care. The investigation, or each and every investigation is one process. Prescription is another major process in any healthcare organization. And if you are going to do certain procedures like surgical and therapeutic intervention, the OT process, the operation theater environment and the process is very important. The evaluation of how the process happens and the documentation is very, very important. The data and documentation are the two important Ds, the way we use data for quality improvement. The third aspect is outcome. So this may be expected outcome or unexpected outcome. So this is basically the measure of the physical or behavioral response due to health intervention or due to the process. So this may be a good outcome or bad outcome, and this also can be gauged from the patient. So patient satisfaction is also a good outcome. And now NABH also focus on capturing patient reported outcome measures, which is another way of calculating the satisfaction. So how do we select the indicator? So there are certain prerequisites for selecting an indicator. So you have to know whether the indicator is important for the organization. I've seen hospitals capturing many indicators that are meant only for a large corporate hospitals. For smaller organization, it has to be based on the scope of the services the hospital is going to offer, and also the standards. So hospitals going for entry-level standards has to focus on the particular standards that are applicable to the organization. So is the indicator important for the organization? And by measuring this indicator, are we going to improve quality? So whatever you do, whether you are collecting data or using the data for improvement, this have to improve the quality of the organization, quality of the services in the hospital. Who is the end user of the indicator? So this is important because the who should collect the data and who is going to use the indicator is very, very important in collecting the required data. And how often it should be collected. Some of the process might happen once in a fortnight. Some of them can happen daily. So basically, how often it should be collected. So whenever that process happens, the data has to be collected. And in what format it should be collected, either through manual forms or standardized forms, or through some app or through EMR. So the stakeholders have to know what format it should be collected. And once we collect the data, what is the formula to be used to know the indicator? So apart from the prerequisite, the stakeholders should also know about how to ensure that the data is clean. Particularly the quality managers and the committee people who are going to use the data have to ensure that the data is clean. So very often when we collect data, there can be, particularly when you analyze the raw data, there can be some wrong figures or wrong decimals. So all these things have to be cleaned before the data is used for analysis. Who should present the data? This is often a problem when we go for assessment. The quality team would expect the clinicians to present. The clinicians think that it is a quality team's job. So the people don't understand who will present the data. So this should be decided beforehand when they are writing the manual. To whom should the data be presented? This is also important. So when you collect the data and analyze the data, this should be presented to the committee, and then the committee will take this to the higher level people for taking certain policy decisions, or during assessment should be presented to the assessors for analyzing the quality and doing the audit. So basically avoid the drip syndrome. So many organizations are collecting a lot of data, but the information they arrive from that data is very poor. So whatever data you collect has to be used by the organization in a proper way to improve quality or improve the various benchmark standards of the hospital. And one way of presenting the data is visualization. And now with a lot of technological advances and apps, data visualization is a powerful way to simplify the complex data we collect. So in healthcare, we collect a lot of complex data. So unless this is analyzed and presented in a proper format, it may be difficult for the people to understand. So this is one simple way of presenting the data. Green, like a dashboard in our car. So green is your goal. When you reach the green, that means you achieve the target or the benchmark. So red is an unacceptable result. That is a definition of failure. And yellow is the warning zone between green and red. This is one way of presenting the various key performance indicators. So if you have technological support, you can do that. But if you don't have this, don't worry. Manual data is also helpful. Excel sheet comes easily and handy for all these things. So there are certain confusions with reference to the various terminologies. So basically, even though you can say what's in a name, quality and clinical indicators, so there are certain definitions we need to know before going to understand the key performance indicators. So are we measuring something that we have control over and can modify? So that is the performance indicator. And some data with reference to the clinical outcome is a quality indicator. And if there is a standard method and evidence-based value for the indicator, this is again a clinical indicator. Or if you're capturing only a data, it is only the measure or metric. So when you are capturing your key performance indicator, it has to be specific for the organization or specific for the department. It should be measurable. It should be achievable. So KPIs have to be realistic. Like 100% infection free may not be realistic, but if it is 99 or benchmarked with the various organizations or the demographics, it can be achievable. And it should be relevant to the overall goals of the business or the standard objective, and it should be within a time frame. So KPI help to assess all key aspects, whether we are doing the right thing, evidence-based care, whether we are doing it for every patient, equal care, and whether we are doing it for consistently every time to all the patients. So these are the various safety aspects, various parameters of quality improvement can be assessed with the key performance indicator. So how we are going to implement? So any organization going for the entry-level implementation should identify relevant key performance indicator as per the size of the organization and the scope of the hospital. So you can identify 5 clinical indicators and 5 managerial indicators, and you can note down the formula for calculating the key performance indicators. And once you start implementing, you have to monitor the KPIs. As I said earlier, validate the data and collect feedback from the various stakeholders. You have to analyze the data and perform a corrective action and preventive action. So if there are any deviations, and once you do that, you have to recommend, the committee will recommend changes, and also the quality manager and the committee will implement certain follow-up measures. So there are certain examples of clinical indicators. The new hospital are going to implement quality can use these examples of clinical indicators and adopt as per their requirement. So these are the examples of clinical indicators. Mortality rate is one key mandatory indicator. Then infection related indicators, catheter associated UTIs, the surgical site infections, errors in reporting the lab or radiology reports, the redoses or in labs or radiology is an important indicator. Surgical re-exploration, again, it helps in knowing the efficacy of the surgical team, and return to emergency within 72 hours, reintubation. So all these are examples of clinical indicators. So as per the scope of the services, you can adopt the clinical indicators. So this is the examples of some of the indicators. So you have to define the indicators. So this indicator is for incidence of fall in the hospital. So patient safety defines fall as loss of upright position that results in landing on the floor, ground, or an object, or a sudden uncontrolled unintentional movement. So this has to be captured through incident reporting. So the frequency is ideally monthly, and the formula is number of falls per number of discharge and death of patients into 100. And this is another indicator where return to emergency within 72 hours with similar presenting complaints. So this gives the efficacy of the assessment process and the discharge process. Then percentage of transfusion reactions. So if you're going to give blood, so this is mandatory that you capture the incident reporting for the reactions. So definition is all transfusion reaction that is happening. Formula is number of transfusion reaction by number of transfusions into 100. The second aspect is the managerial indicators. So these are some of the examples of managerial indicators: the OPD waiting time, average length of stay, or ALOS, the waiting time for the procedures, the OT and IT utilization, the equipment downtime, the errors in billing. So this can happen with insurance or even non-insurance patients, the needle stick injuries. So all this can be part of the managerial indicators. So one of the important indicators that organization capture is the outpatient satisfaction index, because it's the expression of the gap between expected and perceived characteristic of a service. So formula is the score achieved. So based on the parameters you collect from the patient and the score achieved and the maximal possible score into 100, that gives the outpatient satisfaction index. The same way with inpatient also. An average length of stay. So this is again used to measure the duration of a single episode of hospitalization. So if you are a daycare hospital, the inpatient days are calculated as 1 day. So person entering and leaving a hospital on the same day have a length to stay of 1. And this have to be captured monthly. OT utilization rate is important for hospitals having number of operation theaters to see how the resource, the critical resources used. So the OT utilization time on hours by resource hours into 100. Then percentage of medical record not having discharge summary. This is a good indicator for the efficiency of discharge service. So the number of medical records not having discharge summary by number of discharge and death into 100. So these are the KPIs that are relevant as a managerial indicators. So based on the size of your operations and the scope of your operation, you can have various KPIs in hospital practice to focus on key areas, whether it's operation related or finance related or emergency care related or internal KPIs or even the communication KPIs can help in managing the hospital in a better way. Whether you implement quality or not, having KPI in your hospital is very, very important for knowing the progress. Now insurance capping up in big way. So you need certain KPIs with reference to the insurance process. It may be related to the cashless, the shortfalls, or the claim submission rate, the rejection rate, all those things. So how do we go about this? So identify the key operation areas for your, if you are going to implement entry level as per the requirement, there are certain mandatory KPIs. If it is a large hospital, based on the 5th edition, there are about 60 to 64 mandatory KPIs. So plan your format for data collection, set your target value, and analyze your data and actions planned based on your analysis. So this is the simple way: identify, measure, analyze, and then improve. So how do we document this standard in the Apex manual? So list the quality indicators and write down the methodology of capturing the data, and also include the formula for calculation of KPIs and details on who will capture the data, who will analyze the data, and who will present the data to the committee, to the management, to the assessor, and all those things have to be documented in the Apex manual. and who will monitor the changes. That is also important. So basically, the KPI system provides vital data to all stakeholders, to the staff, to the management, and also to the leadership. So selecting the right measure and measuring things right are both art and science, and the KPIs is influence management behavior as well as business culture. So to conclude, so this is the overview of CQI standard for entry-level hospital, CQI 1 and 2. So there should be a structured quality improvement program, and the organization should identify key indicators to monitor the structured process outcome. So this will help in the continuous quality improvement of our hospital through measuring quality indicators, doing a plan, do, check, act, and then incorporating the cultural change. So it's very important to have a feedback loop where you're constantly thinking about what you've done and how you could be doing it better. So that concludes the CQI chapter. So any questions, I'll be happy to take. Thank you so much for your kind attention.
Thank you, sir. Thank you very much. That was a very elaborate talk that you had given on CQI chapter. Basically, for the participants, if you don't measure, you don't improve. So that is the key mantra that Dr. Nirmal Fredrick gave you today. So we have some questions, sir. So I'll just read out some questions. I think you could answer it live. So Shailesh has asked, what is the adequate time period for the implementation of quality program in a 100-bed hospital?
Okay, so the time period depends on the, so when you start, you do a gap analysis. And if generally most of the clinical part, the first 5 chapters, already the organization would be achieving 70 to 75%. So you have to implement only the managerial level standards. So generally for 100-bedded hospital, it takes somewhere between 6 to 9 months. Okay, if you have all the resources in place, all the licenses in place, and then it would need 6 to 9 months time. And if there are resource shortage, it might take a longer period.
And from Shweta, what should be the mandatory indicators for any hospital undergoing entry-level accreditation, irrespective of specialty or number of beds?
Okay, a good reference point would be the mandatory indicators given in the 5th edition book. So there are, so previously the 4th edition, it was 64 mandatory indicators. So as per the scope of your hospital, whether it's a small hospital or it's a single specialty hospital, so based on the scope of your services, you can select the mandatory indicators. So the indicators I showed, say 5 clinical and 5 managerial or mandatory indicators. So this is defined based on the statutory requirement also, right? For example, fire requirements are mandatory. So basically the structural indicators with reference to fire it will become mandatory. So those structure indicators. And if you're having your operation labor ward, if you're having a laboratory, accordingly, the redo rates will also become mandatory. So it all depends on the scope of services and the statutory requirement for the hospital.
And from Swati, what is the difference between re-exploration and unplanned return to OT?
Okay, so unplanned return is, it includes unexpected as well as emergency return also. Re-exploration, sometimes the surgical team itself would have planned for re-exploration. For example, I would suggest in my field, a trauma patient who would require re-exploration if there is an infection. So if there is no infection, we would not explore. But if there is an infection in the first week, we would like to re-explore and do a vitrectomy. So that is a planned re-exploration. So that means re-exploration is basically a planned one, only the time is not planned, whereas the unplanned within 72 hours, it includes planned as well as unplanned.
And another question from Swati, how to capture the clinical correlation for radiology and laboratory?
Okay. So I am not a radiologist, but so generally how organization capture is, there will be a provisional diagnosis, and you have to match up with the report that comes from the radiologist. See whether it is in tune with the provisional diagnosis. So whenever you send a patient for CT or MRI, you send the patient with the provisional diagnosis and the required radiology services. And the radiologist does that particular service and gives a report. So if it is in match with the expectation, then that is in tune with the referral and need. But if it is not related to the provisional diagnosis, that means there is a mismatch between these two. So then that has to be upgraded, or the clinician should be oriented to that.
And a question from Malik, what is the content of discussion in mortality audit committee? What kind of discussion will happen there? I think that's the question.
Okay, so in mortality meetings, generally the senior management see whether the care provided is in tune with the guidelines given by the national agencies or this standard of care. So any deviation from the standard of care, that is discussed. The antibiotic policy or any other policies, so most of the organization will have a care plan. So if there is any deviation to the care plan, that would be discussed. So if there are the progress interventions, so based on the assessment and reassessment, if progress interventions are not done, that will be discussed. So if there is any medication error or adverse event, that will also be discussed. So most of the mortality meeting will discuss both whether the care has been provided as per the standard of care, as per the protocol of the hospitals, if there are any adverse event, whether that was tackled properly, and if there are any incident report or from that particular patient care, that will be discussed during the mortality.
And from Unity Hospital, the question is, who has to make the annual training plan?
Basically, if it is quality improvement program implementation, the quality manager with the help of the HR department will make the quality calendar, will make the training calendar. If it is a regular training calendar, the HR department will.
Anusha sir, the question is, can you give us a few examples of dental clinical indicators?
Right, dental as such, okay. So all the clinical indicators that are applicable to a single specialty hospital will apply to dental also, because we have a list of clinical indicator for ophthalmology so that is published in our book. In dental care, maybe particular aspect of dental care, a dentist would be able to give in a better way. But with reference to like KPI related to infection control, KPI related to the patient satisfaction, KPI related to the small procedures done at the dental chairs. So all this would be common for all the small specialties hospitals. If there are any dentists here, I think they would be in a better position to focus on this particular aspect.
I think there's no dentist in our panel for today.
Okay.
But I think that will answer the question. And there's a question from another person from Colonel Chabi. How can you involve clinicians in this program?
Okay, that's a difficult part. But many hospitals who have gone through 1 or 2 cycles of accreditation have been successful in involving the clinicians, right? So one way is give them certain role and authority to implement this standards. So clinician involved programs are doing very well in many of the hospitals. So one way is to give them some authority and also give them certain time, because many of them are burdened with their clinical duty, so they may not be interested in the quality part of the work. So you can reduce their workload on the clinical aspect and then give them time. So maybe 1 or 2 days of a week they can be given leave for their regular OPD or IPD duties and given time like that. Third one is the management discussing these things, management getting involved and discussing these things with the clinical leaders. So this has given good results, because once the clinicians are interested in certain aspect of the quality implementation, they do it well. So only there are a lot of practical difficulties you've seen in many hospitals. The quality manager mostly is a non-medical person, so they tend to insist more on documentation and all their data work, which clinicians may not require. So that is not their key role. So you have to really have a proper discussion with the quality team and the clinicians, and take their viewpoint also, and then try to involve them. So that really worked in many hospitals.
And a question from Malik again, who, and maybe I'll add when, should they, who has to collect and analyze the outpatient and inpatient feedback? Who and when?
See, most of the hospital collect this data in a standardized format or in the EMR itself. Particularly, we have an app for patient satisfaction. That is, data is captured, and the quality person or the OPD manager can collect the data and analyze the data. Presentation, generally, the analysis part and presenting part should be done by the supervisory level people. So either people from the quality team or from the operation side, they can analyze and present the data to the management or the assessor. And again, all these things should be discussed in the quality meeting and should be communicated to the front office team or the OPD team.
So, last question would be, what are the quality indicators captured by nurses?
Okay, nurses quality indicator, I think it is again mentioned in the 5th edition book. Basically, nurses capture the infection control related, the 5 mandatory infection control related parameters with reference to HIC data. The other code is the number of falls. Again, incident reporting is done by the nursing staff and captured by the either the senior level nurses or the department level staff. So the nursing indicators basically again deals with the structure, the number of nurses on duty, number of nurses requirement for each shift, and the key areas where they're going to operate. For example, in dialysis or labor ward or in ICU. So it's a vast topic on the nursing excellence. One reference book would be the nursing excellence standards. That also gives the number of data to be captured. And again, 5th edition has a list of mandatory indicators with reference to nursing standards also.
Thank you, sir. Thank you very much for patiently answering all those questions. And it was a great session today. Thanks for accepting our invite and being here today. Thank you.
Thank you. Thank you, Adel.